The function of esophagus is to transfer food from mouth to stomach. This delivery of food from mouth to stomach is a well-coordinated activity. This is brought about by muscles of the esophagus and the enteric nervous system. The muscles of the esophagus is a variable combination of both skeletal and smooth muscle. In the upper one third, it is purely skeletal muscle. In the middle one third, it is made up of skeletal and smooth muscle. And in the lower one third, it is a purely smooth muscle. These muscles also do contribute for the formation of upper and lower esophageal sphincter. The upper esophageal sphincter is made from skeletal muscles, that is the cricopharyngeus muscle. The lower esophageal sphincter is made from smooth muscles and that always remains tonically contracted. This contraction state of lower esophageal sphincter prevents reflux of acidic gastric content into the esophagus. Coming to the enteric nervous system, the enteric nervous system is made up of Meissner plexus that lies in the submucosa, mind reflexus that lies in the muscularis externa between the longitudinal muscle and inner circular muscle. The role of Meissner plexus is to aid the secretion. However, the mind reflexus is mainly responsible for the contraction of the muscles. In esophagus, these plexuses are innervated by the vagus nerve. Peristalsis refers to a series of involuntary wave-like contractions that propel the food bolus in the digestive system. This delivery of food bolus across the digestive system brought about by sequential inhibition and excitation around the food bolus. The inhibition is brought about by neurotransmitter like nitric oxide and vasoactive intestinal peptide, and excitation for muscle contraction is brought about by acetylcholine. There are three types of peristaltic waves has been described. The primary peristalsis begins from the swallowing reflex. It is coordinated by the swallowing center located in the medulla. Secondary peristalsis begins as a stress response to the food bolus. It is mediated by the enteric nervous system located locally. Tertiary peristalsis, also known as tertiary contractions, they are non-peristaltic in nature and they are non-propulsive. They are predominantly pathological in nature, suggest some underlying motility disorder. Now let us understand the motility disorder of esophagus. Motility disorder of esophagus starts with dysphagia to both liquid and solid, while solid dysphagia is predominantly a symptom of structural disorders of esophagus. Whenever we suspect a case of motility disorder of esophagus, an investigation is done known as high resolution manometry. High resolution manometry is the gold standard investigation for motility disorder of esophagus. In this, a pressure measuring catheter is placed in the esophagus and pressure is measured during swallowing. The measured pressure is plotted in a color-coded graph. This color coding represents the pressure within the esophagus. Blue color represents lower pressure, red represents higher pressure. This one is the location of upper esophageal sphincter and this one is the location for the lower esophageal sphincter. The break in the upper esophageal sphincter represents the following. As the peristalsis wave passes through the esophagus, the pressure within the esophageal lumen increases. The discontinuity in the lower esophageal sphincter pressure represented by lower esophageal sphincter relaxations. This happens in combination with the swallowing as a coordinated action. The lower esophageal sphincter pressure is measured as integrated relaxation pressure. Integrated relaxation pressure represents the average low pressure measured in the esophagogastric junction during swallowing. In brief, high resolution manometry is the gold standard investigation for motility disorder of esophagus. In high resolution manometry, we measure a pressure known as integrated relaxation pressure. Integrated relaxation pressure represents the lowest pressure measured at the esophagogastric junction after swallowing. So, whenever the lower esophageal sphincter fails to relax, as in achalasia, it leads to high integrated relaxation pressure. Chicago classification is the classification that is utilized to classify motility disorder of esophagus. It divides motility disorder of esophagus into disorder of esophagogastric junction outflow or disorder of peristalsis. Disorder of esophagogastric junction outflow is characterized by abnormal median integrated relaxation pressure. However, disorder of peristalsis is characterized by normal integrated relaxation pressure. Example of abnormal high integrated relaxation pressure is achalasia cardia. Motility disorder with normal integrated relaxation pressure is distal esophageal spasm. Achalasia cardia is a motility disorder of esophagus characterized by absence of ganglion cells in the mind plexus. Due to lack of ganglion cells, there is no nitric oxide. Because of absence of nitric oxide, the lower esophageal sphincter fails to relax. It remains tonically contracted. The tonic contraction of the lower esophageal sphincter is brought about by acetylcholine, which activates calcium calmodulin pathway of smooth muscle contraction. Three different terminologies we may encounter in relation with the achalasia. One is the primary achalasia, is the most common variety. There is idiopathic degeneration of the ganglion cells in the minor plexus. In secondary achalasia, there is a secondary cause for degeneration of the ganglion cells in the minor plexus. The cause is dependent on cruzi infections in Chagas disease. There is another terminology known as pseudoachalasia, is seen in the setting of malignancy. The malignance can mimic achalasia, causing dilatation of the esophageal lumen and tapering at the level of the gastroesophageal junction. The diagnosis of achalasia cardia is done with high resolution manometry. The manometric finding of achalasia cardia are: this is represents the following. As swallowing progresses, we don't see any peristaltic wave of contraction passing. There is aperistalsis, and the lower esophageal sphincter fails to relax. There is impaired relaxation of the lower esophageal sphincter. Because of the impaired relaxation of the lower esophageal sphincter, there is high median integrated relaxation pressure. The role of a barium swallow is to assess the severity of achalasia cardia. In imaging, you can see there is beaking of esophagus towards the GE junction with proximal dilatation of the esophagus. This classical beaking or tapering of the esophagus is known as the barred beak appearance. On the other hand, sometimes the esophagus is grossly dilated, giving a sigmoid configuration. This is known as sigmoid esophagus. Achalasia cardia is treated with surgery. The less severe variety of achalasia cardia can be treated with pneumatic balloon dilatations, peroral endoscopic myotomy, or Heller's myotomy. However, the more severe variety of achalasia cardia, like the sigmoid esophagus, fails to this kind of treatment. They are treated with esophagectomy. Pneumatic balloon dilatations refers to a procedure where endoscopically a balloon catheter is placed at the level of the lower esophageal sphincter and balloon is inflated. Inflation of the balloon leads to dilatation of the lumen at the level of the lower esophageal sphincter. Peroral endoscopic myotomy is an endoscopic procedure where a submucosal tunnel is made with the help of endoscope and the lower esophageal sphincter muscle made with the circular muscle is cut. Third one is the Heller's myotomy. This can be done with open or laparoscopically, where the lower esophageal sphincter muscle is cut longitudinally and distal esophageal spasm, also known as a diffuse esophageal spasm, is a motility disorder of the esophagus where multiple tertiary contractions observed in the distal two-thirds of the esophagus. This classical appearance on barium swallow is known as corkscrew esophagus. On manometry, there is the lower esophageal sphincter relaxes normally. That is why the median integrated relaxation pressure remains normal in diffuse esophageal spasm. However, there is premature spastic contractions observed in the distal two-thirds of the esophagus. The management of diffuse esophageal spasm or distal esophageal spasm is mainly medical. Three different entities that is used: botulinum toxin, calcium channel blocker, and nitrates. Botulinum toxin acts by blocking acetylcholine. Calcium channel blocker acts by blocking long-acting calcium channels, which prevents muscle contraction by blocking the calcium calmodulin pathway. Nitrates release nitric oxide, which helps in relaxation of the lower esophageal sphincter. Now the learning points. Peristalsis is a coordinated involuntary activity which helps in transferring food from mouth to stomach. Tertiary contractions are mainly non-propulsive in nature and they are predominantly pathological. Acetylcholine is the excitatory neurotransmitter and nitric oxide is the inhibitory neurotransmitter at the lower esophageal sphincter. Liquid dysphagia, in addition to solid, points in favor of motility disorder of esophagus. High resolution manometry is the gold standard investigation for motility disorder of esophagus, where integrated relaxation pressure is measured. Abnormal median integrated relaxation pressure suggests disorder of esophagogastric junction outflow, while normal median integrated relaxation pressure suggests disorder of peristalsis like a distal esophageal spasm. Achalasia cardia is characterized by idiopathic absence of minor plexus, marked by impaired relaxation of the lower esophageal sphincter and absence of peristalsis on high resolution manometry. And classically, it appears as barred beak on barium swallow. Degeneration of ganglion cells in Chagas disease is a cause of secondary achalasia, and pseudoachalasia is a mimicker of achalasia due to malignant infiltration. Pneumatic balloon dilatation, peroral endoscopic myotomy, Heller's myotomy are the treatment options for achalasia. Diffuse esophageal spasm is characteristic appearance of corkscrew esophagus on barium swallow. Medical management options are calcium channel blocker, nitrate, and botulinum toxin.